I want to talk to you about atelectasis, which we commonly see in clinical practice. And here's the case. A 62-year-old man is dyspneic about 24 hours after he underwent a cholecystectomy. His respiratory rate is 22, his pulse is 112, he has mild fever, and decreased breath sounds are noted on the left lower lobe. His white cell count is 27,000. So here it is. 24 hours he has dyspnea after he underwent cholecystectomy, right? He has shortness of breath and he has decreased breath sounds on the left lower lobe, and he has a leukocytosis. So this is the typical patient we get. Now right away you should think about, well, you see the leukocytosis and the mild fever and you say, wait a second, maybe he's got an infection. But surgical infections usually don't occur before 2 days after the surgery. So 24 hours after the surgery, this is too quick for a surgical infection to occur. And unless the patient has been in the hospital before, it's likely that this is not thromboembolic disease. You could say, wait a second, maybe he had thromboembolic disease after the surgery, because he was in bed all the time and stuff like that. And thromboembolic disease causes dyspnea, and you may get some decreased breath sounds on the left lower lobe if you have an infarct, right? And you may get some leukocytosis, but usually a cholecystectomy now is an elective thing. Patients come in the night before in the hospital, and they undergo the cholecystectomy. They stay the day, after, and then they go home the day after. So that, unless this guy has some other reason that they're not giving us in the history, I wouldn't suspect a pulmonary embolus either in this patient right away. What I would suspect is something that commonly happens within 24 hours after the surgery, and that's atelectasis. And atelectasis is a collapse of part of or the entire lung, depending on how bad the atelectasis is. It occurs usually in the immediate postoperative period within 24 to 48 hours, and it has to do with poor inspiration, the lack of cough, all the medication that we give to the patient, right, the anesthesia, the pain medication, and sometimes these patients look like they have some kind of infection. They have dyspnea, they have a light fever, right, and they have a leukocytosis, maybe from the atelectasis, maybe it's post-surgical, the post-surgical leukocytosis that we see, but it confounds things. But you should think about atelectasis if this patient has the symptoms right after the surgery within 24 hours. That is the most likely diagnosis. Now, there are other forms of atelectasis. The case that I presented to you just now is the most common one that we see in clinical practice, but there are other cases that are non-surgery related, and we need you to know that. So for example, sometimes a patient has cancer, right? And this obstructs the bronchus and causes atelectasis. Or in a little kid, a foreign body aspiration, or foreign body aspiration in an adult who is prone to aspiration, like somebody who has a CVA and has difficulty swallowing, right? Their swallowing mechanism is compromised. Or somebody that has seizures and loses consciousness. Alcoholics lose consciousness and they could aspirate foreign bodies. So please, if a patient has atelectasis in a non-surgical setting, please think about these things. Foreign body, cancer. It's very important. We see x-rays all the time of patients with atelectasis, and somebody says, well, this is just atelectasis, they're no big deal. Well, wait a second. Why does the patient have atelectasis? And then you go back to the patient's history, and you find out they have a 50-pack-year smoking history. That atelectasis there may be due to a small mass. So please be careful of that. So we talked about the tachycardia, the dyspnea, the x-ray, right? Remember, you got a collapse of the lung in atelectasis, so the trachea deviates towards the side of the lesion, right? That's important. And if it's big enough, sometimes it's not. The atelectasis is small, so you don't get much tracheal deviation. But if it's large enough, the deviation occurs to the side of the lesion. Now, compare that to pneumothorax, where you insert, you insert air in there. Everything deviates away from the lesion in pneumothorax, is pushed away. So atelectasis, tracheal deviation goes along with the lesion. Look for it. What do we do in these patients? Well, nothing much. We really don't have to do much. What do we do? We should have tried to prevent it in the first place by making them walk around, ambulating quickly and stuff like that. And then we do some other stuff, incentive spirometry, pulmonary toilets, you know, these machines they put by the bedside and they have the patient breathe in and out, right? So they expand their lungs, they get back their cough mechanism, their breathing mechanisms and so forth. And you try to avoid, you know, a pain medication and anesthesia as much as you can in the post-operative period. That's how you prevent it. Most of these, 90% of these go, they get better on their own within a couple of days, and it's not really a big deal. Rarely is the atelectasis from secretions that are big enough to cause big atelectasis, and in that case, sometimes, that's about 5% of the cases, we get the pulmonologist to go in with a bronchoscope and pull out the secretions and basically open up the bronchus. But that's rare. Most of these cases, they're going to ask you about incentive spirometry, you know, pulmonary toilet, breathing, you know, physical therapy, early ambulation, avoiding opiate analgesics and stuff like that. That is your mainstay in the treatment and the prevention of this disease.